Welcome, everyone, to Beauty and the Surgeon podcast. I'm Amy. I'm a nutritional therapy practitioner, and I'm joined today by my Cupidity co-host, Dr. Jason Martin. You do make people's love lives better.
I do.
You do. You're like Cupid.
Yeah, I'm the love doctor.
You are the Cupid of plastic surgery. Joined today, as always, by Dr. Jason Martin, board-certified plastic and reconstructive surgeon. Was that Nils shooting an arrow
Yep.
at us? Oh, little heart arrows. We have a great episode today, Dr. Martin, and there's a little bit of a story behind it. First off, if you are not watching us on YouTube and you would like to, you can find all of our social media handles here. We are everywhere at Beauty and the Surgeon podcast, and on YouTube, we are at Jason Martin, MD. So there's a story behind this episode. I have a YouTube channel as well where I vlog about my trials and tribulations as an NPC bikini competitor. And someone who watches my vlog actually reached out to me to ask if we had episodes about implant removal. And I said, we do, but big caveat, they're old and they're really more about some of the issues with implants, but we talk about Explant.
So how old was that episode?
It was 2017 and 2018.
That's crazy.
Yeah.
That's so crazy. I feel like that was just yesterday, actually.
So do I. But it's,
so
think
nuts.
about it. We had just moved in. I think it was one of the first episodes that we recorded in our new studio.
And was that was that an ALCL episode?
It was. We had blessed implant controversies.
Blessed breast.
Blessed implants.
Yes.
Those blessed implants, talking about breast implant controversies. And that's why I thought, well, we were due to re-record this anyway.
Right.
And
Perfect.
we've never actually done episodes dedicated to just removing implants because we've always done it with something else. And it's typically something that's not great, like an implant, related cancer or illness or something, which we will touch on in this episode. But it was such a great recommendation. So I've been burying the lead here. The episode we were talking about today is everything you need to know about breast implant removal, aka explant surgery, and this is part 1 of 2.
I think this is very apropos. I get asked about this more and more lately. It's in our zeitgeist, in our culture. People talk about it a lot more. People wanting to have more natural size, natural size breasts too. So I think this is a very apropos episode. I'm just so surprised we haven't done it for 6 years.
Well, and we've never done it by itself. Ever.
Yeah, that's so weird.
So this was great. So thank you so much.
I mean, we've done hundreds of episodes. This is a big topic. So I'm so happy we're doing this today. Well done.
Yeah.
To whoever commented on your other YouTube channel.
Yes.
Thank you.
Yeah. So thank you so much. So this is part 1 of 2 and when we do these kind of surgery specific episodes, we talk a lot about how to know if you're a candidate, what to expect at your consultation. And then we talk about the specifics. I can't with the words today. It's because it's cold and my nose is running and I apologize up front to Nils because I'm going to be sniffing.
It's because it's cold.
It's
the temperature.
Cold. I have blamed everything on that.
Okay.
Last time it was the time change.
Yeah.
That
totally.
Fair enough, Nils. Yes.
Yeah. I mean, how many excuses could one person come up with?
Oh man, the cold. What is it? 5 degrees
maybe
outside
it's your
today?
supratentorial issues.
That's that too.
Your cabeza.
Yeah. See. So in part 2 is where we're going to talk about the specifics of surgery, including the types of removal and that kind of thing. So if you don't get everything answered in this one, which you will not, listen to part 2, which will be coming out in 2 weeks. All right.
Nice.
Without further ado, we have something very exciting on this first slide. I'm just filling up the whole mashup right here in this first intro of this episode.
It makes it way more entertaining for me, just so you know. So just keep mispronouncing words.
Keep bringing the S words. So we finally have updated statistics from the American Society of Plastic Surgeons, which is awesome. Yes, we've been waiting. We've been going off the real weird 2020 statistics for many years now. So we finally have updates. So these are looking back at 2023 because it's always a little bit behind. I mean, we have just started 2025. So with breast implant removal, there's 2 categories. There's going to be male and female. And then within those, there's also going to be cosmetic and reconstructive. And they are broken out. But in 2023, they were both up. And this was over the year prior, which they never gave us statistics for to use on the podcast, but they're both up from the year prior, which is kind of cool. I mean, we saw a lot of this, things being way down when we were looking at the 2020 numbers. So seeing the more accurate numbers, I think is pretty cool.
I could have predicted this. Yeah. But I mean, 10% is a huge jump. And remember, this is self-reported. These numbers are self-reported. So you're getting kind of a sampling of the cohort. You're not getting a full description, but this is pretty accurate. So 10% increase is a lot from year to year.
Oh, absolutely. And even for reconstructive purposes, there was a 4% jump, which is also really big. So I thought that was really interesting.
And is this implant removal only or implant with replacement?
Only removal.
So interesting.
Yep. And that's what we're focusing on in this episode is removal only.
Okay.
What I found really interesting was the age groups here. And I think this is really indicative of what you were saying about kind of where we are societally. If you look at the two biggest age categories, it's from 40 to 70, essentially, which encompasses two age categories, is the bulk of the removals. And I think that just shows that, perhaps women who had implants when they were in their 20s and 30s have just decided, and we see that in our practice, that is true. You get into a certain point in life and you just, are ready to have them out or, just for whatever reason. And we'll talk about a lot of those coming up. But I thought that was really interesting.
Yeah. At least in our experience, anecdotally speaking, but we do a lot of these cases, it's definitely people over 40. That's the general type of patient. Every decade of life, you gain weight, their breasts get bigger and more droopy. And a lot of people just say, I'm just kind of done with them. It's kind of a hassle. You have to do an MRI.
Don't jump too far ahead on our slides.
I know. That's what I do. That's what I do. That's my MO. Yeah.
Yep.
But, it's kind of
focus on the statistics.
Yeah, it's kind of a general narrative for when these people come in. It's the same story over and over.
Yeah, I agree. Interestingly enough, I found it somewhat interesting that there were statistics for under 19.
Yeah.
Which hypothetically, breast implants are only FDA approved for women over 22.
Right.
That's silicone. Yep. The saline can be implanted over 18. There were only 13 reported. But I did find that somewhat interesting just because those you would assume were all saline.
Well, you could...
or for recon.
Yeah, it could be recon. Poland syndrome is the one we talk about, where people have non-development or underdevelopment of one breast.
Even that, 19 and under.
Yeah, but you can... Poland syndrome, I'm pretty sure...
You could probably get approval at 16.
For silicone, actually. But I'd have to look at that, actually. There are reconstructive purposes for these. Yeah. So that's maybe what it is. But yeah, the propensity is, if you look at this data, 40 and plus is the majority of the cases.
Yeah. So very interesting. All right. Let's talk about, like Dr. Martin got to was jumping all over my slide.
That's what I do.
Why
I'm here, Amy.
Yes. Why would you explant? Why would you want to have your breast implants removed? It's a good question. And there's a lot of reasons.
A common one is...
Well, let's first say this.
Okay, so breast implants are not a lifetime device. We've said this many times before, but we're going to say it again. FDA made a big push. What was that, 2022, 21?
That was 2017 when we first started talking about breast explants.
I feel like we're like, what is...
yes, that was when the consent.
This time has changed. Anyways... They came out with a big push, especially with the development of ALCL, and said, you have to educate the patients. And literally, they told the companies that make these implants, and also the companies then passed it on to the physicians to do it. But these are not permanent devices. So that's the main part of breast augmentation. And I'm not sure why. And I guess it's just because of education that people get confused about that. It is not permanent.
Well, people don't like thinking about the future.
Right. Yeah.
What is that in Spaceballs? What are you looking at?
Spaceballs again. Are we going to talk about the nose?
Right. No. Let's get the...
Can we just have a movie that we talk about?
Yes, it's that
people
one.
Know. Nils knows Spaceballs. I know Spaceballs. No one else knows.
You have to do it with me. So they're looking, what are you looking at? The future. I'm
yeah, they're looking ahead. Yeah. That's pretty funny.
Can we go back to now?
Yeah.
When will then be now?
Just missed.
Yeah, just missed.
Just now.
Yeah, just now.
All right.
But yeah, people have a hard time thinking about the future. It can be anxiety provoking. Also, it's you could have breast augmentation. It could last forever. We've had patients where they've had 40-year-old implants.
That's still not forever.
Yeah.
Means we know that because we're taking them out. So yes, they're not a lifetime device. That's the really important thing to know.
Yeah.
Really simply, you're bothered by the size or appearance of your implants.
Which is the most common. A lot of people over 40 have had breast augmentation a while back. For whatever reason back then, they would tend to put in pretty large implants. People come in, they just feel like their implants are too big for their body. Some people are like, hey, I liked them back then, but now I'm done with them. Yep. So it's usually too big, asymmetric. The next one that Amy talks about here is capsular contracture, was a real common problem with aged implants, and capsular contracture is scar tissue around the implant. We've had amazing episodes dealing with capsular contracture. That's probably in 2017.
It is.
Anyways, so
please don't judge us.
Yeah, capsular contracture is very common after breast augmentation. It's more common with reconstruction, but even aesthetic or cosmetic breast augmentation, it's a pretty high percentage over 7 years. So heavy, hard, and painful.
Mm-hmm. And that kind of goes with capsular contracture. Typically, I mean, every implant, I think this is the one thing that people get confused about. Every breast implant will have a capsule around it. That is normal. It's capsular contracture that becomes a problem. And that's when that scar tissue starts to overproliferate and harden and contract.
And contract in three-dimensionally. The sphere is squeezing in. So you get this super tight implant squeeze.
And the irony of that is the breast gets bigger.
Yeah.
As that scar tissue builds up, like it can sometimes be like double the size of the other breast by the time people address it, which
the
is
scar tissue is thick, or it can be distorted in shape. So it looks bigger, but it's just the upper pole is much bigger.
And some people just have pain with their implants, even from the beginning.
Oh.
They don't like the way they feel. They make their muscle hurt. They pinch.
Well, think about it. If you had a scar contracture around a moving muscle, that's going to hurt when you move.
Even when the implants are soft.
And when they're soft too.
We have a reconstruction patient who from the day she had a reconstruction has complained about pain with her implants.
100%. Yeah. And like you want to think that that's like a costochondritis, like an inflammation.
That's what we thought at first.
Right. And it's like, after a while you realize the body, it just irritates the chest wall. And a lot of times with people with bad capsular contracture, another thing they complain about, and I've seen this in reconstruction and both aesthetics too, it's hard. And so like when you hug someone,
they hate the way it feels.
They hate the way it feels. It's very concerning. They get self-aware. You can imagine like, do they feel this hard rock on my chest? Which
they
is basically,
do.
And they do. So rupture and leak, the rupture rates of newer implants are definitely lower than the older ones, but they're still there. That's why the FDA recommends a screening MRI 5 years after placement of silicone implants, because those ruptures can be fairly silent. Whereas the saline implant, if it ruptures, you know it. And why do you know it, Nils?
Because it leaks.
Because it leaks. It goes flat.
Yeah.
I think I've told the story before, but we had someone that called it, the front desk person who was great. It's not our current one, but she's like, well, how do you know it ruptured? She goes, because one breast is like a C and the other one's like an A.
Like a pancake.
I thought that was pretty funny. The patient was like, well, I'm looking in the mirror. It's not inflated anymore.
Yeah, it happens. And that's when people say that they think it's leaking and they have saline. I'm like, well, you would know. There's no thinking,
Yeah.
Although we did have the patient who had this, and when Dr. and I first started working together, silicone breast implants had just come back on the market. So there were a lot of women that had saline implants still. And it leaked about half out, but then the implant kind of rolled on itself and like stopped its own leak.
That is absolutely true.
Yeah. So she had a vacation to go on. She's like, I think it's going to be all right. She's like, I'm going to do my vacation, like fix it when I come back. Cause it was still kind of like half full.
And per memory, the vacation was to a beach area.
It was.
Like she was going to have to wear a bikini. And I was like, this is going to be kind of dicey, but do it when you come back.
If it does start to leak, how long does it take before it like goes flat?
Sometimes they just wake up and
really
it's flat.
quick. Yeah,
so saline's a lot less common now, but in the old days when the silicone was off the market, we had a lot of people and they would know within a day.
Yeah, you just wake up one morning and it's like gone.
Yeah.
Like driving over a nail. Yeah.
Yeah, exactly.
By the time you get home, it's
Very good comparison. It's like your tire on your car. You go, the night before it was kind of low, you go out the next day, it's totally flat.
Gotcha.
You just can't call USA roadside service. You got to call plastic
fix a flag. You put a little hose in it and fill it back up.
Like we just patch it. Yeah. Get one of those. What was it for the air mattresses?
Yeah.
They always came with those little patch kits.
Totally.
So expanded clothing options is a big one. There are a lot of women that come in and say, I'm just sick of my clothes not fitting.
Yep.
Or we have a patient who had like really nice designer clothes and was sick of having them altered.
Yeah, this is actually more common than not.
Yeah.
They're like, I'm okay with my breast. The shape might be okay. Maybe they don't have capsular contracture, but it doesn't allow them to wear the type of clothing that they want to wear that they think fits their body. And most of the times, if you look at them, they're absolutely right. They're imbalanced and they need more balance in their body.
Athletic pursuits for us, at least in Colorado, I would say this is our number one. Our patients who are avid athletes, and it's interesting, even the ones who, love their implants, when I talk to them after they've had them removed, they all say that their athletic ability improves. In fact, one of them who is a cyclist, so really tracks all of her metrics, her VO2 max went up after she had her implants removed. She was actually breathing more and breathing better. And she had a moderate implant. She had not a big implant.
I mean, you could imagine that the excursion of the chest wall could somehow be blunted by an implant, but it would be so minuscule, but maybe
unless you're an elite athlete.
Yeah, I mean, if you're an elite athlete, maybe every little millimeter counts.
Oh yeah, especially for cycling. I mean, if you can increase your VO2 max by even like 1 point, yeah, that's a big difference.
The other one we see is rock climbing is really big out
Golf.
here. Nordic skiing, which definitely uses your pectoralis muscle. Golf is huge. Tennis, pickleball. Yeah, big time. So it's a common Colorado request.
Yeah. And then, of course, the one that we kind of have talked about a couple of times is BII, breast implant illness. And this also in the episode that Nils has already linked, breast implant controversies, we talk about this a lot. And then the big scary one is breast implant associated anaplastic large cell lymphoma. I almost made it with saying that perfectly.
No, you did pretty good.
Yeah, pretty close.
Yeah. That had so many words that I was asleep by the time you got to the end of it.
Which is a type of lymphoma. It is not breast cancer.
It's a T-cell mediated lymphoma. Yep.
That is only associated, as the name indicates, by breast implants. And the solution to fix both of these issues is to remove your implants.
And the capsule.
Yes.
A full capsulectomy.
Yeah. So we have a full episode where we talk about that in detail. So we're not going to belabor the point here, but just know that that is the solution to those problems is removal. All right. Who is a good candidate for this procedure, Dr. Martin?
Well, this may rock your world. As someone who's healthy enough for surgery, Amy.
Yes, this is elective surgery.
I don't think I've ever said that on this podcast before. Someone who's a non-smoker. Smoking, I was looking at the smoking rates, they've really gone down, but vaping's gone up. So I don't know if it's really much better because vaping's not going to really be much better than smoking.
And that includes marijuana.
Right. So, but smoking definitely decreases your ability to heal and increase the chance of postoperative infections. A stable and a happy weight. This is actually really important because if you take implants out, you're going to change your body balance. So a lot of times we'll take implants out in the office, and we'll talk about this on the second episode, and we'll do fat transfer at the same time. That's like a very common surgery we do these days. And obviously you want a stable weight when you're trying to equal out the breast volume in comparison to their body.
Good skin integrity and muscle tone, these aren't necessary per se, but they definitely will make your results better, which we'll talk about as well. Obviously, you have to have breast implants, right? To be a good candidate for this procedure, you have to have breast implants. And I think the biggest one, I mean, it seems like it would go without saying, but I mean.
I guess that's true.
Yes, you do need to have breast implants. And I think you really have to be kind of mentally and physically aware enough to understand the process of removal. You know, that there's going to be, like Dr. Martin said, there's going to be phases of how it looks. Your body contour is going to look a little bit different for a little bit of time. Like, I think those are really key things. Right.
So a lot of it's dependent on your exam, just like everything in plastic surgery. And we'll kind of go into some of this stuff. But in terms of if you have really droopy breasts, maybe you're going to consider something else. But what Amy was kind of alluding to is there's a process after removal where you look deflated. And then a lot of times your skin will kind of retract in if you have pretty good skin integrity. And so you're going to have this kind of middle period where you have to be mentally strong.
Well, and for the same reasons we talk about, like, will plastic surgery make a person happy, that breast implants actually have the lowest happiness rates, and unfortunately some other not great statistics that go along with it. When you have placed a lot of your self-worth on the way your breasts look, especially look to other people, it's important to be ready for the fact that changes. And I think it's both things, you know, like, people don't focus on as much as you want them to, but then the people who did, you get used to that attention. Like there is that component of it that emotionally
there's a duality
for
sure.
Yeah. That's different than other surgeries.
But by and large, again, we'll talk about all this in the future. It's not a super aggressive surgery unless you don't have to remove all of the capsule. We can talk about that later. But in a lot of these times, if you don't have a bad capsule, we can do it in the office with you totally awake. We do the fat transfer with you totally awake. So the point is that it's something that is easily facilitated.
And most people with implants are good candidates.
Right. If you have breast tissue and you're not too droopy or ptotic, but there is a mental component of this, I think, that has to be addressed beforehand. So afterwards, you're like, okay, I'm ready to go.
Yeah. And we talk a lot about that coming up as well. All right, let's take a quick break. And when we come back, we'll be back for the rest of the episode. And we're back. All right. So let's talk about what options there are for explanting.
Yeah.
And this is what you were kind of alluding to, that there's a lot of options. Explant only, no capsule.
Right.
So just take them
the
out.
people that come in with BII or capsule concerns or capsule contracture are not going to be a candidate for this. There are people that come in with very soft breast, doesn't clinically have evidence of capsule. Obviously, Amy said correctly that everyone has a capsule. Your body walls off this foreign body.
That's anything that's inside your body, any type of implant, not just breast implants.
Right. But this is, by and large, the majority of the people that come in our office for implant removal, they don't have a bad capsule, and they're candidates for in-office with an explant only.
Yeah. And then the next option is explant with capsulectomy or capsulotomy. Dr. Burton, talk about the difference between capsulectomy and a capsulotomy.
Okay.
I did this to myself on this episode.
That's right. I love it. Listen, you are a magnificent person with a really, really, really good brain. I love the fact that you have one very obvious deficiency, because it makes me feel better about
the
myself.
Achilles heel is
deficiencies.
Real easy bullseye to hit.
All right. So if you know Latin, an ectomy is removal. And that can be subtotal, okay? So not all of it, or a total capsulectomy. And otomy is just kind of making small incisions in the capsule. That's an otomy is actually helpful if you're putting an implant back in, but most people, if they are concerned about the capsule, they want an ectomy, they want a removal. And to this point, actually, our National Society came out and gave some guidance, because with the advent of ALCL, BII, people were really wanting to come in and have a full capsular removal. And they came out and gave some guidance and said, well, if that's necessary, do it, especially in the case of ALCL. But in some cases, it can be very destructive. So a subtotal capsulectomy, a sub percentage, maybe greater than 80% or 90%, is really helpful and does the majority of the work that you want. But, it just depends on what the conversation you have with the patient, and also what the clinical indications are.
Mm-hmm. Absolutely. Yep. Then you've got your explant with lift,
which is very common. We do this all the time.
Yep. Explant with fat transfer, which Dr. Barnes mentioned a few times, which is a great option to replace some of the missing volume from the breast implant. In most cases, it cannot even come close to matching the volume just based on the size, but it can definitely help kind of fill the area in.
So the smallest implant they manufacture is how big, Amy? I mean, like the general ones, like 120?
Yeah.
Or 100?
There are some in that very, very low 100 range.
Okay.
Yep.
So like a good fat transfer is going to give you 100 cc's.
Yeah, 150.
At the most.
Yep.
And not all that fat's going to make it, even with the best technique.
Yeah, we have a great episode about fat. All about fat.
All about fat. That was actually a really good episode.
Yeah.
I love that episode.
Also an old one. Also maybe needs a redo.
Either we're getting old, or we need to really talk about our topics. So the reality of fat transfer definitively is that it's only going to equate to the smallest manufactured implant they make, which no one uses unless you're super petite or you really don't want to have a change.
Well, or you're using it to just add, you're matching a recon side.
Yeah.
That's when we've used
really
them.
Good point. Reconstruction is a good point.
Yeah.
So, but fat transfer is great. And you said at the bottom, a combination of above, which is what we do.
Yeah, it's probably all of them.
Pretty much all the time.
Yep.
So we'll do the implant removal. I'll do a subtotal capsulectomy, not a total one, because that could be pretty destructive. I'll do a mastopexy and then a fat transfer, pretty much on almost all of these patients, and with really good results.
Mm-hmm. Yeah, there's a lot of options, which is really great. We didn't used to have as many options per se, but now we've got some really good ones, especially with fat transfer.
Yeah.
So choosing a surgeon, this is very important.
I mean, I feel like we should ask Nils this question, but I don't know. He might not know the answer.
Yes. So you want to make sure that your surgeon is board certified in the country that you live in. In the United States, it's the American Board of Plastic Surgery.
What is it in Canada, Amy? Do you remember that one?
The Royal Academy of Surgeons. Yeah. And we looked it up, and it's almost the same thing in the UK and in Ireland. It's like the Royal Academy of Surgeons in Ireland and the UK. And as a reminder, there is no American Board of Medical Specialties that recognizes a certifying board with cosmetic surgery in its name. So if your doctor says they are a cosmetic surgeon, that is not the same as being a plastic surgeon. And even if they say they're a plastic surgeon, get on the American Board of Plastic Surgery's website and check, please. We have a really great episode where we talk about how to choose a surgeon. It's one of my favorite episodes. It's the new beauty guide, How to Choose a Surgeon. Fantastic.
Going to show it here.
Yep. They have results and aesthetics that match your desired outcome. And most importantly with this is someone you feel comfortable with, because as I stated before, this can be an emotional surgery. It's like a little bit of an emotional journey.
Yeah.
So you want to make sure that you feel comfortable with your surgeon. You know, you guys are on the same page, that they're honest with you.
There's definitely more emotion involved in this surgery than the opposite when you put the implants in.
I don't know. I think people are usually super happy. Like I'd say it's 90% of people.
No, the emotional hurdles that you have to overcome sometimes with these kind of decisions, as opposed to putting the implant in, which tends to have more of an impulsive feel. So
yes.
This feels more definitive to people. So therefore, there's a lot more angst about the decision. So I think being in an office where you can at least talk it out is important. Obviously, you want a technically proficient surgeon. That's the most important thing. That's ethical. But also having an office staff at the very least you can have that conversation with. You can look at pictures. Hopefully they're good at fat transfer is one of my specialties. They're good at breast lifts if you need that, especially for post-pregnancy in your 40s and droopy breasts. So I think it's really important that you have at least an office that you feel comfortable in.
Yeah, and that goes for any surgery. But
especially for this one, I think, because it's such a definitive decision.
Yeah. Well, and here's the great thing, and this is what I say to all women or men who are deciding to have breast implants. They're not a lifetime device. Take them out, put them in, change the size. Like they're
it's
not
like the
permanent.
hokey pokey,
yeah.
Right.
So if you take them out and you decide you want them back in, you can do that. Like you don't burn a bridge by taking out your implants. You can always put implants back in.
It's like a video game, man. Just start over, reboot.
Yeah, exactly. Yes. All right. So let's talk about what happens at the consultation.
Yes.
They're going to do a full medical history. Please tell them about all of your surgeries. You'd be amazed how many people come in for a breast implant exchange or a removal consultation and don't list their breast implants as one of the surgeries they've had, which like, yeah, I get it. You had them, but like when? or all the people who think they don't.
Do you want that information? Yeah, that's why you're here.
That they don't need to tell us about
We absolutely love our patients, but it's so amazing how they get blindsided by cosmetic surgery questions.
Yeah. Like if all your surgeries, not just your non-elective surgeries, your current medications, please tell them if you have a history of smoking and or a current smoker. Just be honest. It's not a judgment thing, but we need to know. Allergies, supplements you're taking, drug use, that's marijuana, previous surgeries, all that good stuff. They'll discuss your outcomes, expectations, give you a quote, review the risks and potential complications, review before and after. What did I just say? What was that word I just said? Did I say review?
Yeah, review. It doesn't matter.
Okay.
View is basically short for review.
Yeah, I'm like, did I say a real word or was I just making words up? It just has an RE
in front of it. It's okay.
Yeah.
Here, I'll keep it.
Well, but this is the point, and I'll let you talk about it, of similar expected outcomes.
Yeah.
Because breasts are so different. People will bring us pictures of things that I'm like, this is nowhere near what your body looks like or what you can expect.
So if you are 21, you haven't had kids, and you decide your implants need to be removed when you're 25 and you still have breast tissue, that's not a fair comparison to a 40-year-old post-pregnancy with breasts that are drooping because of breastfeeding in pregnancy.
Or someone who's lost 100 pounds.
Yeah.
Like there's so many reasons why people's breasts look different.
Right. Also, a breast lift, we have excellent episodes on that, but a breast lift is great, but it's going to leave more scars in your breast than you have with a breast augmentation alone. So that's something to consider. So looking at photos, looking at what the scars look like, look at what fat transfer does after removal. It'd be great if we had pictures, which we don't, of the removal and then what the fat transfer looks like after we did the removal. Maybe we can do that in one of our office cases.
Yep.
I don't know if you could. You'd have to sit the patient up. That'd be kind of weird. But.
Yeah. Yeah. But I think that's the important part. I mean, I know everybody, that's the biggest concern for people is what are they going to look like after? And rather than like torment yourself by trying to find what you think they're going to look like after on Google, let your doctor show you some pictures of people that at least are somewhat similar to your body shape and size and your age and presentation, rather than get yourself really concerned. And, I think that's a lot of women that come in are really kind of freaked out by what they've seen online, by people talking about their explant experience.
Do you find it maddening on Google to find images of something you're looking for? Like the other day was just looking for, who was it? Benedict Cumberbatch. And I just wanted a normal picture of him, and I could not find it.
Were they all?
It was like all like, formulated pictures and things
like AI generated ones,
like kind of weird ones. Yeah, and I was like, why can't you just get a normal picture of this dude? I mean, he's very well known. I mean, I just want to picture him walking down the street, and I literally looked for 10 minutes and it wasn't there. What?
What do you need? What do you need? A picture of him walking down the street
I don't really
for?
care about Benedict Cumberbatch, by the way, but I was just in this rabbit hole, and then I kept thinking to myself, this is what patients go through trying to find real images.
Only worse, they're seeing the worst case scenario.
Yeah,
they're seeing horrible things.
So maybe ChatGPT and that kind of stuff will change it. I doubt it.
I think it'll make it worse.
Yeah, maybe.
Yeah.
So that's why it's so important when you go into the office to have them sit down and look at real pictures.
Yeah, non-edited, real pictures.
Yeah.
And then answer any questions that you have. This is always something that Nils links below, but some questions to bring to ask your surgeon, and these are always going to be in the description box. Number one, are you board certified? Are you a board certified plastic surgeon? This is number one. Do you perform surgery at an accredited facility? That's a really good question.
Right. Or is it in a tent outside in some field somewhere?
Right.
With a generator.
Well, I mean, unfortunately, there are
people like that. I mean, it's not a tent, but it might as well be that kind of place.
What specific training do you have in breast implant revision techniques? These are important questions. Am I a good candidate for this procedure? What surgical technique is recommended for me? And
if they look at you and say, I do the best surgical technique, then say, which one is that? That's always the best response. Because arrogance is always a way to cover up insecurities in our field.
Right. I'll let you read these next two, starting with this one.
Will breast tissue or capsule be sent for examination? In a lot of cases, it will. If you're in the breast cancer rate, I mean, to be honest with you, in most cases, I would. Yeah. If I'm doing a lift, I'm going to send the breast tissue off, even if you're in your 30s, and that's going to have a fee. I mean, through your insurance company, the pathologists have a fee, et cetera, et cetera. So that's going to cost some money, but that's absolutely worth it. Amy, how many times have we found occult breast cancer on somebody with a normal mammogram? I mean, like at least 3 times per memory I can remember.
Yeah, it's not. I don't want to freak people out. It's not super often, but it happens.
Well, I mean, but if you're one of those 3 people, thank you, Dr. Martin.
Oh, no, I'm not saying it's bad. I'm just saying, like, I don't want to scare people.
Right. So why not send it off, for a little extra cost to it? Yeah. Less likely you'll send the capsule off, but you will send the capsule off if you're concerned about ALCL. We talk about it in our episode on that, and that is where they send it for flow, FLOW. I spelled this last time.
Yeah, and I said spell cytometry.
And I'm going to keep on selling it because I'm not going to spell cytometry. I
Voodoo
refuse.
economics.
No, I'm not going to. CYTO. No, I can't do it. Flow cytometry. And what that does is looks at the clonal aspects of that tissue as it regards to T cells. And if you have a certain type of clonal amplification of a certain type of T cell, then you could have ALCL, or that actually is diagnostic.
Yeah, that is. Yeah. What are the risks and possible complications?
Yeah, this is such a good question.
If they tell you there are none.
Right. That's a problem. And there's definitely complications that could occur. In general, breast surgery does not have many life-concerning or life-preserving kind of issues, meaning that there's like the bad outcomes that you think of in your mind are unlikely with breast surgery.
Yeah, but you can still get a DVT.
You definitely get a DVT. You could have a chest wall injury. But the stuff that does matter, which is important, is loss of sensation to the nipple and areola, loss of skin and soft tissue.
Oh, we do have a slide where we talk about these complications.
Yeah, all right. Bleeding. There's so many different possibilities that aren't life-threatening, but are really scary and concerning. So you need to have that conversation with your surgeon.
Yes, along with how would complications be handled. I think two that are pretty important are, will weight gain or loss affect results? And how can I expect my breast to age over time? Those are two questions that you should definitely think about. And that's why on our slide about who's a good candidate, we're not trying to weight shame anybody, but you should be at a stable weight, because losing or gaining weight, especially postmenopausal women, will, they'll be like, my breast got big again. What happened? Just those hormonal shifts can cause breast tissue to kind of start to grow again. Gaining weight can certainly do that. So if your doctor is asking about your weight and how stable it is, or if you've lost a lot of weight and they're wanting you to wait a little bit before you do surgery, there's a reason why, because it's to optimize your results.
Yeah.
No amount of surgery is going to stop aging. And we talk about this on all of our episodes.
Besides my surgery, of course.
It will pause it.
Our office is the one exception when I do a face and neck lift.
I mean, I hope it isn't, because there would be no repeat customers, unfortunately. So,
that is a good point.
Yeah.
We'll just put a timer in there, 10 years, and then it all reverts back and we start all over.
Well, that's the myth of the breast implant in general.
Yeah.
But you're going to continue to age. And if you need a lift and you're in your 40s, you'll probably want/need another lift in 10, 15 years. That's just life. Another couple ones that are really, really good. What are the options if I'm dissatisfied with my outcome? And we talked about the emotional side of this surgery. And then do you have pictures of results that are reasonable for me to expect? The dissatisfied with the outcome, I think that's always a concern. Like, well, what if I don't like it? Well, like I said, we put them back in.
So there's a big part that we had a case like this. Patient had very large implants, very distorted looking breasts, and bad capsules. she wanted the implants out. She was just done with them. And I said, look, if we take these out, do the lift and the fat transfer, which we did, and it's just hard to get used to, we'll put implants back in. Very good results. She was happy with the way it looked afterwards, but she's like, I liked it better with implants, but this is the good part. We put in smaller implants. So delaying replacement of implants is actually a really good way to do it when you have obliterated and distorted breast from previous surgery.
She also had a rupture, and she was also in a really bad car accident.
Yeah.
So that she had other compounding factors that made it a better choice to just remove them. But she's the only patient in the entire time you and I have worked together who's ever had her implants put back in. The only one, even the ones we've planned to.
Right. And I find that intriguing.
Yeah. And she's in her 60s.
In her 60s. Yeah. But also what I found intriguing with her is that she was very open and honest.
Yeah.
We were having open and honest discussions, and she was like, yeah, it looks good, but I just kind of want a little more volume that fat transfer can't give me.
Yeah. Well, in the feel too, like she'd just gotten used to the way her breast, that firmness of having a breast implant, and she liked it.
Yep.
Which it was so intriguing. I'm with you. It was such an intriguing thing because I would never have guessed that she would be the one that asked us to put them back in.
Exactly. That's why it pops in my head. Because if I would have, it was game theory, I would have said she's definitely the one who's never putting it back in.
Because she had a lot of breast tissue.
And she did. And you know what? She was happy. And also she did not feel a sense of loss that she had taken them out. Yeah. But most importantly, if you have very large implants in a huge pocket, it's really hard to narrow down that pocket. It costs a lot of money to put grafts in at the time of surgery, which we do a lot. To downsize your implants, to take out the capsule, you have to put the grafts in. It's a lot of stuff going on there. It actually is probably easier and maybe ultimately better just to delay placement of the implant after removal. And that's what we did in the old days. So that's the other part of it. If you choose to take it out and say you do a lift and ultimately you're like, I want some more volume back, you can put the implants back in and you're actually doing what's probably clinically and surgically correct overall.
Yeah.
Again, we've only had one patient do that.
Yeah. And I mean, they're implants. Like I said, take them out, put them in.
I love how we're saying like all of our experience. It's only one patient.
Yeah.
Yeah. But whatever.
If you do a fat transfer, is there a certain amount of time you have to wait so the fat takes, or how much it, and then do it because you don't want to
We should wait and talk about that when we talk about fat transfer.
Look at you stepping on our toes like I do.
Yeah.
Just because that's a great question, but we
good mentor of stepping on slides over.
Yes. Right. He knows how it's done.
I've taught you well, young Yoda.
Nils asked a really good question that we will definitely address in our next episode when we talk about fat transfer.
I love it.
Yes. All right.
Doghouse Nils.
Mostly because we are at the end of this episode. And I don't want to tromp all over the next episode because we need...
This is when I wish they didn't have copyrights. We could just play next episode by Dr. Dre.
You could sing it.
Yeah. Probably not going to do that. We'd probably get flagged for that too.
No, you can sing stuff.
My voice is too good. Yeah.
That's right. You don't want to, seriously, putting that out there, nobody gets that for free. Yes. Yes. All right. Well, so that does bring us to the end of episode 1 and on the cliffhanger from Nils, because he asked an amazing question that we will absolutely cover in detail when we come back, because when we come back on our second part of this breast implant removal episode series, we're going to talk about your pre-op appointment, how to plan for post-op, what to expect for recovery.
We're talking about the best day ever, which is your surgery.
And the specifics of surgery, which is what Nils was just getting at.
And then Amy's true expertise, which is recovery.
Preparing for recovery. All right. Well, thank you all so much for being here. If you would be so kind as to do me one amazing favor, it would be to like this video, share it with a friend who might be considering having their implants out, and subscribe. Subscribing is free. If you never listen to another one of our episodes again, I totally get it. That's fine. You can just subscribe and just move on with your life, and I would still love it. You can also send me a text message. In 1 month from today, there will be an episode where we actually answer listener questions. So those are some of our favorite episodes. And most of those people have left comments on our YouTube videos, which you can do in the comments section below, or you can shoot me a text or leave me a voicemail at 303-630-9038.
Did you read that, or was that from your head?
It was a combination of both. I was glancing. But Nils double checks me.
You're like a newscaster. Your eyes don't move, but you're still reading at the same time.
Nils fact checks
Professional.
Yeah. So we thank you all so much for being here, and we'll see you here next time.